Alhamdulillah, wassalatu wassalamu ala Rasulullah wa ala alihi wa sahbihi wasallam ajma'in. Inshallah, today we are going to talk about approach to the child with short stature. My name is Professor Abdulmoein Al-Agha from Faculty of Medicine, King Abdulaziz University Hospital. This is my website, aagha.ku.edu.sa. All my lectures and my presentation available in this website. First of all, what is the definition of short stature? The classical definition of short stature, whenever we have a child whose height is below 2 standard deviation below the mean for age, gender, and race. 2 standard deviations means third percentile. So we have either to use below 2 standard deviation or below third percentile. All of them are true. If you said short stature is height below third percentile or height below -2 standard deviation. This is the classical definition. What do we mean by classical definition? This is the most common acceptable definition, but there are some other variable definitions where we should consider it as pathological. For example, a child is still on the 25th percentile, for example here, but his growth velocity is low. And whenever he has very slow growth velocity, means that he's crossing down the percentile year by year. For example, he was last year on 50 percentile, this year still in 25th percentile. So when he presenting to your clinic and he's still in 25th percentile, you said by definition it should be below third percentile, so you tell the mother and the father, tell them your child is normal. No, you have to be sure of the growth velocity before you take the decision of normal child or short child, because he was previously on the 50 percentile and now on 25th percentile. If you left him like this, maybe after 2 or 3 years or 3 years, he or she becomes below third percentile, and then you investigate after 2 or 3 years. So instead of wasting time for the parents, you have to take full history and full examination, including previous growth height readings before, if available. If not available, you could ask the mother indirectly about the growth velocity by asking her what size of clothes your child wear, is it appropriate for age or not, and is his clothes getting shorter year by year or the same size of clothes. So we have to consider growth velocity as an important issue in evaluating any child with short stature, as well as, if you can see on this slide, you have to draw up the measurement of mid-parental height on the last age of the chart. For example, here 20 years, you have to draw the mid-parental height as well as plus minus 2 standard deviation of mid-parental height, which is plus minus 8.5 centimeter. So for example, if the mid-parental height is 160, the plus 2 standard deviation is 160 plus 8.5, which is 168.5, and minus 2 standard deviation of 160 is minus 8.5, so will be 125.5. So we have to draw the mid-parental height as well as plus 2 standard deviation and minus 2 standard deviation, and you have to see is the current child height is within the mid-parental height or not within mid-parental height. So 3 important values we have to consider in evaluating any child with short stature. First, what is the exact height, in which percentile? Number 2, what is the growth velocity? And number 3, is it within the mid-parental height or not? The term dwarfism was used in the past, should not be used at all. Should not be used at all now, because it is not a good name or not good description of short stature when you said dwarfism. Sometimes, as I mentioned, height is within the normal percentile, but growth velocity is consistently below 25th percentile over 6 to 12 months of observation. So in order to judge on the growth velocity, we have to have at least two measurements in 1 year, 6 to 12 months measurement to see what is the growth velocity and is it within the normal range or not. It should not be confused, short stature with failure to gain weight, because we have two terminologies. One is short stature means height, and the other terminology is weight. Whenever we have a weight below third percentile or -2 standard deviation below the mean for age, sex, and race, that is not short stature. Weight is not short stature. Weight is failure to thrive in younger age group and failure to grow in older age group. As I mentioned, target height, which is the mid-parental height, should be calculated. So target height is the same of mid-parental height, should be calculated and should be plotted on the growth chart as mentioned earlier. And whenever we have a child with short stature, we have to select the appropriate growth chart. For example, a female chart should be used for females and male chart should be used for males. I've seen many errors from my colleagues, students, and junior doctors when they plot a male on a female chart or vice versa. The same thing, the age, because we have two categories of growth charts, one from 0 to 36 months of age, and the other one from 2 years of age to 20. Sometimes a child age is 2 years, and I've seen it before, it was plotted on age of 2 months. They use the growth chart of 0 to 36 months of age. The other common mistakes also to plot syndromes on the normal growth chart. For example, Down syndrome should be plotted on Down syndrome chart. Turner syndrome should be plotted on Turner syndrome chart. Prader-Willi syndrome should be plotted on Prader-Willi syndrome charts. So these children, these dysmorphic children and syndromatic children, they have their own growth chart. If it's not available in your clinic, there is no harm if you can print it from the internet, from the website, from the CDC or WHO website, and you can plot your child on the specific chart and put it in the file. Also, for those with skeletal dysplasia, for example, achondroplasia, hypochondroplasia, they have also their own chart. So the message, these children should be plotted on appropriate growth charts. If syndromatic, as I told you, you should plot on the specific chart, Turner syndrome chart, Noonan syndrome chart, and Russell-Silver chart. The way where height is measured should be accurate. And this is another mistake. We face it in our clinical practice. Some nurses and some helper, they don't measure the height in appropriate way. The child should be standing in this way or should be lying. Any age below 3 years of age should be a supine measurement, and above 3 years should be a standing measurement. The accurate measurement is like this. First of all, he should not be wearing any shoes or any socks. Should be his foot should be with nothing. Heels and back should touch the wall. There should be no space of the heels or the back should be touching the wall. He should look straight ahead. There should be a gentle and firm pressure upward of the neck, so to make his neck straight, and this measurement should be done 3 times and take the average reading of the 3 readings. Another important measurement is to measure the body proportion, the upper segment and lower segment. Practically, we cannot measure the upper segment. Lower segment measurement is much easier. So lower segment, we measure it from the symphysis pubis to the floor. And then when we have a lower segment, we subtract the lower segment reading from the total final height. For example, the final height is 130 centimeter. The lower segment is 65 centimeters. So 65 centimeter subtracted from 130 will be another 65. So we put in the upper segment في البسط ولور segment في المقام. We see upper segment, lower segment ratio. Normally at birth, the ratio upper segment to lower segment ratio 1.7. At 3 years of age, the usual ratio is 1.3, and above 7 years of age till puberty, 1:1 ratio. Why we need to measure the upper segment and lower segment? Because we have to differentiate whether or not we have proportionate short stature or disproportionate short stature. Proportionate short stature means the upper segment, lower segment ratio is normal. Disproportionate short stature means there is discrepancy between the ratio of upper segment to lower segment. What are the factors affecting the growth? Number one, genetic factor. We never ever ignore the genetic factor in short stature evaluation. We have to evaluate the father height, the mother height. Also, we have to ask about other relatives' height, other siblings' height, the aunt, the uncle, the grandfather, grandmother, because the child could inherit short stature from any one of the family members, not only from father and mother, can be also from father, mother, from the uncle, from the aunt, from grandfather, grandmother. So all is very important. Very important to ask about history, intrauterine history, because intrauterine growth retardation is one of the important causes of short stature. And in order to know about the intrauterine growth retardation, we have to ask about the birth weight of the child. What was the birth weight? Even if the child now is 12 years of age, 14 years of age, still we need to ask about birth weight, birth length, head circumference at birth, and whether or not the child is having intrauterine growth retardation or not. There is also, we have to ask about extrauterine factors involving the growth, especially nutritional history. Nutritional history is very important. Psychological and social history is very important, and unfortunately a lot of our students or junior doctors forget to ask about psychosocial history in evaluating a child with short stature. History of repeated infections, history of medication. For example, a child with rheumatoid arthritis is on steroid therapy and comes to your clinic with short stature. If we didn't ask about history of chronic diseases, if we didn't ask about medication history, we might miss one of the important differential diagnoses causing short stature. Chronic diseases, very important to do systemic review, evaluation. All the systems should be evaluated. Even if the father didn't come and tell you, my child is having congenital disease or having celiac disease, you should ask about the history of chronic diseases in the history, and as well as full examinations in order to discover any of the chronic diseases. Endocrine factors is very important in any child with short stature, especially hypothyroidism and growth hormone deficiency, and children with gonadotropin deficiency presented with a combination of short stature and delayed puberty. Of course, we have to ask about whether your child is having any sort of syndrome. Was he diagnosed with any syndrome or not? Because syndromes is one of the important causes of short stature. Let's see what are the factors affecting the height from the beginning. Intrauterine life does not depend on the growth hormone or on thyroid hormone. Intrauterine growth depends mainly on the insulin and IGF-2, not IGF-1, IGF-2, insulin-like growth factor number 2, and the insulin. That's why infant diabetic mother, they born with macrosomia, because they have a lot of insulin intrauterine. That's why they are big. So intrauterine life does not depend at all on the growth hormone or thyroid hormone. What's the meaning of that? So children with congenital growth hormone deficiency usually they present with the normal birth weight and normal birth length. During the first 2 years of life, the growth depends on the nutrition. Nutrition is very important in the first 2 years of life. In our community, a lot of children does not have a normal or enough nutrition. That's why they might present with short stature because of nutrition. Very important to ask about nutritional history, detailed nutritional history. As well, in the first 2 years of life, thyroid hormone is very important. So any child with short stature in the first 2 years of life, we have to evaluate for thyroid hormone deficiency. From age of 2 years up to age of puberty, the growth, the normal growth depends on the nutrition. So as you can see, nutrition is important factor in all age groups. In order to evaluate a child's short stature, we have to ask nutrition history in any child, whatever the age, present with short stature. A thyroid hormone is very important. A growth hormone is very important from age of 2 years till puberty. And after puberty, in addition to nutrition, to thyroid hormone, growth hormone, sex hormone is very important. That's why children with constitutional, physiological constitutional delay of the growth usually comes at this age. The father notices that, the father or mother notices that their child present with short stature and delay of puberty from age, for example, 10 years and above. Before that, the child was growing normally. So from the time of sex hormone secretion, if there was a delay in sex hormone secretion at that age, from age of puberty, the growth hormone depends on the sex hormone. So very important to evaluate and to ask in history about the pubertal history, and the examination we have to examine for tender staging in any child with short stature. And this is very important and unfortunately missed by a lot of students and medical junior medical doctor to ask about history of puberty and history of menstruation in females with short stature, as well as when they examine the child, they don't examine for tenor staging. Tenor staging is very important in any child with short stature. How to calculate mid-parental height, which is the target height, the same, mid-parental height is the same as target height. If you have a boy with short stature, we have to correct the mother height. The mother's height, we add to the mother height 13 centimeter. And then to add the father height as it is without any correction. The total heights of the corrected mother height and the father height should be divided on 2. And the result will have the result plus minus 8.5 centimeter. As I mentioned earlier, the 8.5 centimeter is plus minus 2 cent deviation for mid-parental height. If you have a child, girl with short stature, we have to correct the father height by subtracting 13 centimeter from the father height and add the mother height as it is. Then the total heights should be divided by 2, the same thing, plus minus 8.5 centimeter. As I mentioned earlier, growth velocity is very important. Growth velocity is very important to evaluate in any child with short stature, because you might have a child with familial short stature below 3rd percentile but having normal growth velocity. This is very important to rule out pathological short stature, because any cause of pathological short stature, they never ever have a normal growth velocity. Growth velocity is affected in all conditions, pathological conditions affecting growth, while physiological short stature like familial short stature, they have a normal growth velocity. Constitution delay of growth and puberty, they have normal growth velocity before the age of puberty, and abnormal growth velocity after the age of the puberty, because they have delayed puberty, so their growth velocity will be affected after the age of puberty is supposed to happen. So we have to ask about the growth velocity, and this table is a summary of normal growth velocity. We have to memorize what is normal growth velocity according to the age. For example, in first year of life, the growth velocity is very high, 25 centimeter per year. In second year of life, the normal growth velocity is about 12.5 centimeter per year. Age between 2 to 5 years of age, the normal growth velocity is between 6 to 7 centimeter per year. 5 years of age until age of puberty, the normal growth velocity is 5 to 6 per year. And during puberty, whereas there is a growth spurt, the usual growth velocity is between 10 to 12 centimeter per year. So growth velocity is very important to evaluate in any child with short stature, and this is the average height according to the age. And also we have to recognize the normal height for depends on the age of the child. Very important notices that the most critical factor in evaluating the growth is to determine the growth velocity. Also, we have to plot various previous heights of the child on the growth chart, if available, to see whether the height is crossing down the percentile, because as mentioned earlier, might be the current height is not below third percentile, but the child is keep crossing down the percentile. So we need to evaluate that child even he or she is on 25th percentile, because the growth velocity is low and the height is crossing down the percentile. Also, we have to have at least 3 measurements in each sitting. The nurse or your helper should measure the child standing up 3 times and take the average readings, and also preferably to have observation 6 to 12 months of the height to know the growth velocity of the child. A child with delayed bone age is not a physiological short stature. So one of the most important differentiating point of physiological from pathological short stature is to do X-ray of the hand, left hand and wrist, and to evaluate the bone age of the child. When we come to short stature, first of all, we have to, from the starting point, to see is the child dysmorphic or not. If dysmorphic, no need to go to all these lists. Dysmorphic means syndrome, so we have to differentiate which syndrome. Is it a Russell-Silver syndrome? Is it a Nolan syndrome? Is it a Turner syndrome, Down syndrome, Prader-Willi syndrome, or part of pseudo-hypoparathyroidism dysmorphic features? Without going to all other causes, this is enough to make short stature, syndromatic short stature. But if we don't have a dysmorphism, a child looking normal by the examination, so we have 2 categories in a normal looking child. Proportionate short stature, as I mentioned, by measurement upper segment and lower segment and making the upper segment lower segment ratio, and to see whether this ratio within the normal ratio or not, or disproportionate short stature when we have discrepancy between upper segment and lower segment ratio, which is not in the normal range. If you have a normal range, upper segment, lower segment ratio, we have to look into this differential diagnosis. If you have abnormal ratio, so disproportionate short stature, we have to see this list. Disproportionate short stature, the commonest causes of disproportionate short stature is what is called skeletal dysplasia. Skeletal dysplasia, either we have 2 categories, short trunk dysplasia or short limb skeletal dysplasia. Short limb skeletal dysplasia, the commonest cause is either achondroplasia or hypochondroplasia, and this is one of the common disorders. We see it in our clinical practice, skeletal dysplasia with short limb hypochondroplasia or achondroplasia. By the way, when we have a short proximal segment, we call it rhizomelia. Rhizomelia is a description of short segment, short stature, short segment, short proximal segment of the limbs. When we have a short trunk, child might have deformity, spinal deformity like kyphosis, scoliosis, or might have spondyloepiphyseal dysplasia. All these under skeletal dysplasia, all of them have abnormal ratio. So very important in our examination to do the ratio and to decide whether normal ratio or abnormal ratio. If we have a normal ratio, so then the differential diagnosis, either physiological short stature or pathological short stature. Physiological short stature, we have two causes. Number one is familial short stature. Number two is constitution delay, growth, and puberty. Pathological short stature could be the child might born with a small for gestational age, birth weight, IUGR, or the child have chronic malnutrition, the child might have celiac disease, the child might have chronic illnesses like chronic renal failure, chronic liver disease, child might have endocrine causes like growth hormone deficiency, hypothyroidism, child might have chronic lung disease like cystic fibrosis, chronic malabsorption, celiac disease. Any chronic disease will affect the growth, and do not forget one of the important factors, psychosocial deprivation. Psychosocial deprivation is also an important factor for proportionate pathological short stature. So if we have a proportionate short stature, we might have normal physiological form. What is the meaning of physiological? Means the child will not have any sort of treatment. Physiological doesn't need any treatment. So if you have a child with familial short stature, should not receive any treatment. If you have a child with constitutional growth delay, should not receive, for example, growth hormone. And that's why very important for a physician to decide whether this child is having a physiological short stature or pathological short stature, because the management is different. Physiological should not receive any medication, while pathological should receive treatment. In constitutional delay of the growth, the child should never receive growth hormone therapy, but in certain situations might receive short courses of testosterone therapy, sex hormone therapy, in order to induce puberty. And whenever the puberty is induced, the child will catch up growth, because constitutional delay of growth and puberty, the main problem is delayed puberty. So when we induce the puberty, the growth will be caught up, and the child will have a normal height. So occasionally we treat constitutional delay of growth and puberty with sex hormone therapy, not growth hormone therapy. If you see other causes of pathological short stature like intrauterine growth retardation, growth hormone therapy is indicated, even the growth hormone is normal. We know in intrauterine growth retardation, when we evaluate growth hormone level is normal, but despite this one, growth hormone is FDA indication if the child born with intrauterine growth retardation and did not catch up growth by age 2 to 3 years of age, we could start growth hormone from age 2 to 3 years of age if the growth not be in normal range after waiting 2 to 3 years from the birth. If we have syndromatic child, the Turner syndrome is one of the indications of the growth hormone therapy, but Down syndrome is not indication. Down syndrome is not an indication of growth hormone therapy, while Turner syndrome is an indication of growth hormone therapy. Silver-Russell syndrome is then another indication. Prader-Willi syndrome is an indication, but provided that the child does not have sleep apnea. If the child has sleep apnea, we should fix sleep apnea first before starting growth hormone therapy, because growth hormone therapy will make more worsening of sleep apnea. Child with malnutrition, we should correct the nutritional status of the child. We have to be sure how much calorie every day, and we have to calculate exact caloric intake of the child, because malnutrition is one of the important factors causing short stature. And in Saudi Arabia, a lot of our children does not have a healthy diet. Their diet is having poor quality of nutrition, for example, biscuits, chocolates, gypsy, and this will never make a normal growth. So we have to advise our parents of normal, healthy food for their children in order to grow normally. Malabsorption syndromes, especially celiac disease. Celiac disease, by the way, is not always present with the classical symptoms of abdominal distension, abdominal pain, wasting. Sometimes it comes with only short stature. So celiac syndrome or celiac disease, very important to be ruled out in any child with short stature. Even does not have abdominal pain, abdominal distension, wasting, wrinkling of the skin, we should rule it out because it might be the only presentation of celiac disease is short stature. Chronic systemic diseases, mentioned before, psychosocial deprivation, we should evaluate it, especially emotional deprivation, child neglect, very important to evaluate. Endocrine causes of short stature, growth hormone deficiency or growth hormone insensitivity, hypothyroidism, diabetes mellitus uncontrolled. Those with poor control diabetes mellitus, not any child with diabetes mellitus or insipidus will have short stature. Only those with poor control diabetes. Cushing syndrome is an important cause of short stature. Pseudo hypoparathyroidism is an important cause, and in certain situations where we don't find any cause from the history, from the examination, from the investigation, everything is normal. And whenever we have everything is normal, but the child is short, and the child is pathologically short. Pathologically short means what? Means height below 30th percentile, means poor growth velocity, means not within the mid-parental height range, and that is the criteria of pathological short stature. So idiopathic short stature is one of the important causes of pathological short stature with everything else as normal. And also idiopathic short stature is one of the indications to receive growth hormone therapy. Disproportionate short stature, as mentioned before, we have either a short trunk or short limb. Achondroplasia, hypochondroplasia, chondroplasia punctata, ectodermal dysplasia, and other skeletal dysplasia can cause a short limb, including also osteogenesis imperfecta. Children with osteogenesis imperfecta, they have a short limbs, short stature, disproportionate short stature. While disproportionate short stature or short trunk, the most important causes spondyloepiphyseal dysplasia, mucolipidosis, mucopolysaccharidosis, those with scoliosis and kyphosis. Diagnosis, very important step toward accurate diagnosis is history and examination. Unfortunately, most of cases of short stature did not have, or those children seen by doctors with short stature doesn't have enough history and examination. So the window to appropriate and accurate diagnosis of short stature, whether physiological or pathological, whether proportionate or disproportionate, whether a normal growth velocity or abnormal growth velocity, whether a good nutrition or not, chronic diseases or not, dysmorphic or not, all depends on the history and examination. Please never ignore history and examination when evaluating in a child with short stature. And then the laboratory evaluation. Laboratory evaluation is the second step after history and examination. We have to concentrate on onset in the history, when short stature has happened, exactly. Is it since beginning, since birth, for example, IUGR? Is it between age of 2 years of age till puberty? Is the short stature noticed just recently when the child supposed to have puberty and did not have puberty? So date of onset is very important in evaluating any child with short stature. Birth history, very important. Birth weight, any history of birth asphyxia, because if there is history of birth asphyxia, the child might have hypoxia to the pituitary gland, so we'll have hypopituitarism. Any intracranial hemorrhage, instrumental delivery, kernicterus at birth, jaundice, very severe jaundice. All history at birth history is very important in evaluating a child with short stature, even if the child is 12 years of age now, 12 years of age. Some doctors said, why I ask about birth history and the child now is 12 years of age? No, birth history is very important to evaluate in the evaluation of short stature. Past medical history is very important, surgical history is very important, complete systemic review is very important, developmental history is very important, family and social history is very important, nutritional history is very important, and allergic history as well is very important. Here is example of some of the clues to the etiology of short stature from the history. For example, if you have a history of delayed of puberty in one of the parents, so we don't only need to measure the height of the father and mother only. Very important to measure the father's height, mother's height, also to evaluate when they have had their puberty. What age? Did they have delayed puberty or not? Because that is very important in children with constitution delay of the growth and puberty. We have to ask about birth weight because that is a clue for IUGR or small for gestation age. Did the child have neonatal hypoglycemia, prolonged neonatal jaundice, micropenis? That is very important in cases of growth hormone deficiency or hypopituitarism. So very important to ask about past history of neonatal hypoglycemia, past history of prolonged neonatal jaundice, and whether the child currently is having micropenis or not. So genital examination is important in evaluating a child with short stature. Dietary intake, nutritional history, very important in cases of malnutrition. Whether the child is having headache, vomiting, visual problem, that will indicate hypopituitarism due to intracranial tumor. And the most common intracranial tumor causing hypopituitarism in childhood is craniopharyngioma. So you have to ask about symptoms of increased intracranial pressure as well as visual disturbances. And you have to examine visual field in any child with short stature because the child might have craniopharyngioma with a visual field defect. You have to ask about symptoms of hypothyroidism like weight gain, unexplained weight gain, constipation, lethargy, sleepiness, bradycardia, cold intolerance. This is very important in cases of hypothyroidism. Psychosocial history is very important, and one of the important factors causing short stature, psychosocial deprivation. You have to ask about malabsorption symptoms like steatorrhea, fatty stool, difficult to flush the stool in cases of celiac and other malabsorption cystic fibrosis. But as I mentioned earlier, celiac disease sometimes present with nothing, only with short stature. And we have to take detailed systemic review for chronic illnesses. What are the clues from physical examination? This is an example. For example, if you have a child with midline facial defect, by examination, we found midline facial defect. Or we found a child with micropenis. Or we found a child with frontal bossing, depressed nasal bridge, crowded teeth. That is a clue for growth hormone deficiency or panhypothyroidism. Sometimes you have isolated cleft lip or isolated cleft palate also is another clue for hypopituitarism in a child with short stature. So if you have a child with short stature and he had past history of cleft lip or palate repaired already, cleft lip and palate is one of the midline facial defect. Central maxillary teeth is another important history point in hypopituitarism. So a child born with natal teeth in the maxillary not in the mandible. Mandible is fine. Maxillary, central maxillary teeth, natal teeth is also is important clue to growth hormone deficiency or hypothyroidism. If the child is having signs of ricket or bone deformity, we have to think about rickets, and ricket is one of the factors or causes of short stature. If the child is having pallor, we have to think of renal failure, malabsorption, nutritional anemia. If the child has signs of malnutrition, clubbing, wasting, we have to think of malabsorption syndrome and cystic fibrosis. If you have a child short and obese, when you plot the weight and height on the growth chart, there is a discrepancy. The height, for example, below 30 percentile and the weight in the 50 percentile. Despite 50 percentile weight is not obese, but relatively obesity for this particular child because his height is below 30 percentile. So that is what is called short and obese. Not necessarily to have the weight above 97 percentile to say obesity and short stature. If there is a discrepancy between height and weight percentile, that is called in endocrine terminology short and obese. For example, child below 30 percentile, height and weight on the 50 percentile, that is considered short and obese. If we have some sort of shortening of the fourth or fifth metacarpals, and that is one of the stigmata for either Turner syndrome or pseudo hypoparathyroidism. If you have a child with cardiac murmur, that might indicate congenital heart disease is affecting his growth. And if you have a child with mental retardation and short stature, you have to think of hypothyroidism, Down syndrome, pseudo hypoparathyroidism. This slide is very important. Always perform Turner staging. Always perform Turner staging. We have to evaluate pubertal staging in any child with short stature. And as you know, Turner staging for the girls, we have to look for the breast Turner staging, stage 1 nothing, stage 5 adult, and the stage 2, 3, 4 in between. Pubic hair in females, stage 1 pubic hair is nothing, 5 is complete adult, and the 1, 2, 3, and 4 in between. In males, we have to evaluate the pubic hair, tenor of pubic hair, 1 is nothing, 5 is adult, and we have to do genital tenor stage of genitalia, 1 is nothing, prepubertal, and 5 is adult mature genitalia. Also, it's very important in a male with short stature to examine the testicular volume, because definition of puberty if the testicular volume above 4 mils. So in order to know whether the child hits into puberty or not, a male child hits into puberty or not, if the testicular volume 4 mil and above, and that is puberty, below 4 mil is still pre-pubertal. Investigations, there are basic investigations for everybody with short stature, and there are others investigation only for a specific situation. For example, the universal or basic investigation to evaluate any child with short stature composed of bone age. Bone age is mandatory to guide you whether this is a physiological short stature with normal bone age in familial form, or delayed bone age in constitutional growth delay, or in other pathological short stature. Bone age is mandatory. Thyroid function test, even no other symptoms of hypothyroidism, because hypothyroidism can present only with short stature, not necessarily to have a child with short stature and hypothyroidism with all symptoms of hypothyroidism. Yes, we could have it, or we could have only hypothyroidism with short stature. Karyotype in girls, because not every Turner syndrome has the dysmorphic features, as you could see. Some Turner syndrome, they have mosaic Turner syndrome. So despite they are Turner, they don't have dysmorphic features of Turner. Some Turners, they have 46XX, they have 2X two X's, but the second X is mal-structured. For example, isochromosome X or ring chromosome X. Despite they have a 46XX, they have the Turner syndrome and they don't have dysmorphic features. So any girl with short stature, karyotype is very important to evaluate. CBC to look for anemia, ESR to look for chronic disease, chronic active disease, electrolyte renal function test for those with renal tubular acidosis, for example, and those with chronic renal failure, liver function test for those with liver failure, urine analysis, because sometimes repeated urinary tract infection is a cause of short stature, and not all urinary tract infection comes with symptoms. It's about 1/3 of urinary tract infection is asymptomatic. So, especially in girls, they might have UTI in the past, repeated UTI with unspecific symptoms, for example, only fever, without other specific symptoms of UTI, suprapubic pain, tenderness. They might have only fever, and they comes with repeated UTI with short stature. Nobody recognizes the cause of repeated UTI unless we do urine analysis, and sometimes we need to do urine culture. Stool analysis, especially giardiasis. Chronic giardiasis is one of the causes of short stature and failure to grow. And as I mentioned before, we have to screen for celiac disease, because celiac disease not only present with abdominal distension, abdominal pain, wasting, sometimes present only with short stature. Bone age, this is what it looks like, and very important to see the epiphysis of the bone, whether or not it is closed or open. What I've mentioned is universal investigation, and now we come to specific investigation if clinically indicated. For example, if the child is having disproportionate short stature, we have to do skeletal survey. If the child is clinically having signs of rickets, we have to do bone profile. If the child is having clinically symptoms and signs of cystic fibrosis, we have to do a sweat chloride test. If the child having positive anti-tissue transchromatase screening for celiac, we have to do jejunal biopsy. If the child is having features of growth hormone deficiency, whether history or examination, we have to do growth factors, IGF-1, IGF binding protein 3, as well as growth hormone stimulation test. By the way, growth hormone, we cannot evaluate growth hormone as basal growth hormone, because growth hormone is secreted from pituitary gland in pulsatile fashion, so it's not always normal physiologically. Sometimes have a pulse, sometimes we don't have a pulse. If anybody evaluates growth hormone by basal growth hormone level, that is a big mistake. Most of the time we'll get it low. So the only way to evaluate growth hormone, whether normal or not, by doing growth hormone stimulation test. Growth hormone stimulation test, there are some physiological stimulation by exercise and deep sleep, no longer used in current medicine. What most of the centers do to evaluate growth hormone, whether normal or not, but do pharmacological stimulation, preferably to have two stimulation. There are big debate whether to use single factor for stimulation of the growth hormone or two factors, two agents. Myself prefer to have two pharmacological agents in stimulating growth hormone. But there are plenty of medication to stimulate growth hormone. For example, the insulin, which is very strong evaluating or stimulating growth hormone, but the problem of hypoglycemia, that's why a lot of centers avoiding using insulin stimulation tests, and I am one of the centers never use insulin stimulation tests in children because of risk of hypoglycemia. I am myself using clonidine, glucagon stimulation test, but other agents like L-DOPA, like ghrelin, like GNH, RH, stimulation test, a lot of agents used to stimulate growth hormone stimulation test. And if the growth hormone is deficient, next step to do MRI pituitary to look for the size of pituitary, whether the child is having malformation of the pituitary gland, or rarely to have craniopharyngioma as a presentation of the growth hormone deficiency. Very important to differentiate between familial and constitutional short stature. Familial short stature, we have to have a positive, strong history of short stature in the family. We have to have a normal growth velocity. We have to have a normal bone age. And that is very important in the familial short stature. While constitutional delay, we have a delayed bone age. We have a normal growth velocity before the age of puberty and then delayed growth velocity. We have a positive family history of constitutional delay of puberty, and when the father or the uncle or the relative got the puberty, they could catch up, their height catch up, and they become a normal height later on. And this is the example of certain the differentiation between familial short stature and constitutional. Familial short stature from the beginning is short stature, but they are running parallel to the curve. They are parallel normal to the curve. So they are short, but with the normal growth velocity. That's why they keep on their growth keep on parallel to the normal third percentile curve. While the constitutionally short stature, initially they have a normal growth velocity, and then their growth velocity drop at the age when supposed to have a normal puberty. And when they go to their late puberty, they catch up and they become a normal final adult height. So constitutional, they reach to final normal adult height, while genetic, they are always short from the beginning. Growth hormone deficiency is one of the examples of pathological short stature. As I mentioned earlier, they have normal length and birth weight because growth hormone has nothing to do with intrauterine growth. And then they start to have growth failure after the age of 2 years. And when we find the bone age delayed less than chronological age by 2 years, this is significant. Also, they have poor growth velocity, less than 4 centimeters per year. This is very important, growth velocity, less than 4 centimeters per year. Bone age delay more than 2 years from chronological age. They might have infantile facial features. They are, all of them, they are intelligent. They have nothing to do with thinking, with mentality. All children with growth hormone deficiency, they have normal intelligence. We have to rule other causes, exclude other causes. We have to exclude hypothyroidism as important cause of endocrine short stature. And we have to confirm growth hormone deficiency by doing growth hormone provocation test. And if we have a result of growth hormone more than 10 nanogram per ml, that will exclude diagnosis of growth hormone deficiency. And this is an example of a child. He was short because of growth hormone deficiency, and when growth hormone replacement therapy started, the growth started to improve and then continue to be a normal pattern of the growth. Last slide, which is take-home messages. In any child with short stature, we have to do, number one, height and weight accurate measurement and serial measurement. We have to calculate growth velocity or height velocity. We have to calculate father's and mother height and to plot the target height on the growth chart. And we have to look for any dysmorphic features. We have to do full history, systemic examination, history and examination of all the systems. We have to evaluate ternary staging. We have to do bone age of any case of short stature and appropriate investigations according to the history and examination. Thank you very much. All the best.